Hello and welcome to the University of Minnesota MHA Executive Interview Series on Global Health Matters. My name is Dan Zismer, Program Chair and Director. I'm here today with Dr. Jim Rice. Jim is the Project Director of a large global health project funded by the U.S. Agency for International Development. Jim is working through the Management Sciences for Health organization, a 40-year-old not-for-profit global health organization. Also, we're proud to claim Jim as a graduate from our program. Welcome, Jim. Thanks for coming and thanks for your time today.
Nice to be here, Dan.
As we begin, talk a little bit about the mission of your organization and your role in that mission, please.
We should look at the mission in two perspectives. The mission of the Management Sciences for Health, the parent organization in which my project is lodged, and also the mission of our project itself, the Leadership, Management, and Governance Project. First, with Management Sciences for Health, as you correctly indicated, it's a 40-year-old organization started by a physician. Its focus is to harness and leverage and apply some of the wisdom and experience and systems that have been learned over the years about how good management has a direct impact on strengthening health systems, and in turn those stronger systems will perform better to have more outcomes that are not only significant but sustained, especially in low and middle income countries. It's where the organization is focused for the last 40 years, and it's a heritage and legacy that I'm able to take advantage of with our team in our project. So I'll talk now about the mission of our project itself, the Leadership, Management, and Governance Project. We are designed and have a substantial amount of resources entrusted to us from USAID to look at having a not only more significant but more sustained impact on health systems strengthening and therefore better outcomes by looking at building the competencies of those that lead, those that manage, and those that govern in some of the challenging countries across the world. We work only in low and middle income countries. That enables us to look at building up the capacity for individuals and institutions that are focused in on leadership, management, and governance activities. We are involved in certainly training activities, but we also have as a mission to make sure those initiatives are sustained. And another part of our mission is to attract and support more women into these leadership and governing roles as well. It's an exciting opportunity for us.
How many people do you work through globally? As I understand it, there are literally thousands of people that are somehow affiliated with your organization. Could you just give us a little profile of the scope and span of the organization?
Inside Management Sciences for Health, we have about 2,000 employees. They come from around 70 countries, and we have offices now in over 30 countries. So we have a large group. In our project itself, we have about 29 people in our Washington, D.C. office. We also have 120 people in Afghanistan, and most of the other countries in which we're working, we have 10 to 15 people. And so we have a growing and expanding leverage of very talented people. We leverage that with host country national health professionals that we work with and contract with in all the countries that we're engaged in.
And how do you find your way to these countries? Are you invited in?
Yes, we can only work in countries in which the U.S. agency has been requested oftentimes by the Ministry of Health to help address some of the leadership and development needs as a means to improve their health system performance. So we're invited in often by the local office in the embassy of the U.S. Agency for International Development, and we have constraints that we can only work in low and middle income countries. So invitation is the first step. That enables us to field a team to help do some diagnosis and scope and nature of the challenge and how we will best intervene to be involved in that country from 1 to 3 years.
Tell us why it's in the best interest of the U.S. government to be investing in the development of healthcare leaders and managers in these countries.
Several years ago, it became evident that the interests of the American people and us as a nation was going to be better served if we didn't ignore some of the problems and challenges in these other countries. There are humanitarian motivations for us to be involved in some of the low and middle income countries. People are dying, especially children and women, because of problems in childbearing situations, and HIV/AIDS, TB, malaria, some of the communicable diseases are a big issue. But beyond the humanitarian initiatives there. If societies don't have stable health care and health systems, it's very difficult for them to have politically stable and growing and vibrant societies. And if you find societies and governments that aren't stable and aren't vibrant and growing, you have a situation, unfortunately, where you create conditions in which extremism will grow and terrorism might flourish. And so there's some self-interest that gets woven into the equation, as well as protecting our interests. And finally, an even more crass motivation is to protect access to some of these markets. As these countries grow, their economies develop, there's an opportunity for goods and services from the U.S. to go there. First order of priority is the humanitarian assistance. And the last thing I would say to bookend this self-interest that we have in investing in health services development and strengthening is that in the complicated society we have now with globalization and mass movement of people, we have diseases that don't know political boundaries either. And so epidemics can rapidly expand across the globe, as we've seen with SARS and other kinds of things. So we've got many motivations to invest wisely into these countries.
How might the work you're doing, or rather, help me distinguish that work from public health work, or are they one and the same in this mission?
For us, they're very closely interwoven. You know from some of my background, my early career was very much involved in making hospital and acute care systems work wisely and well in a number of U.S. states. This new opportunity for me is a chance to marry some of the service delivery things that I have been involved in and learned from over the years with classic public health protection and promotion. We can only work in societies that have low and growing incomes. So we're dealing with the lowest income 50 countries of the world. And most of their challenges thus far are in the public health realm. Their ministries of health are designed to protect and promote health, guard against diseases. They also are worried increasingly now about service delivery as well. And as they face the bimodal challenge of communicable disease and non-communicable diseases, they have to worry about the service delivery infrastructure also. So I think the long-winded answer to your good question is we have to deal with both, protecting and promoting health, the classic what we in the U.S. call public health protection and promotion, with service delivery. It's still largely in the public sector, but we do also work with some private organizations, mostly non-governmental organizations and civil society organizations that are stepping up to help their society deal with these public health challenges.
My guess is resources are relatively constrained in these markets.
Yes, absolutely.
So help us understand the basics of resources, how they're constrained, and what you're doing about that.
Well, with any society, they are struggling to allocate resources into the health sector, both to protect health and promote health and restore health. And although their percent of GDP that's focused on health is not too dissimilar from some of the other average income countries, because they're dealing with a very low national development index, their economies are fairly modest to begin with. A percent of a small income is a lot, not very much money available for the health services area. So they're always scrambling to get resources. And unfortunately, many of their systems aren't working well. So the resources they do have entrusted to focus on protecting health, health service delivery, may also not be as well focused and as efficiently used as possible. So that's another motivation to make sure that leadership and management is brought into the fray so that the resources that are there are used and leveraged as much as possible. So the classic challenge exists, whether it's for Europe or North America, is do more with less. That also applies in the lower income countries. It's just that their challenge to do more with less starts with a smaller base. So it's a real challenge. And it's not just constraints and resource shortage for money purposes, but in health workforce as well.
Is it fair to say that your work focuses on the development of systems of care in these countries? And what's their view of a system of care relative to what we're accustomed to here in the U.S.?
We do work on systems of care. We also work on trying to provide some of the management and leadership and governance of those systems so that the systems work well and wisely. The system design is quite similar. The work of the World Health Organization over the last 30 years has developed a fairly common understanding of building blocks you need for a nation's system to protect and promote health and make sure service delivery occurs at high quality and is cost effective. But the system emphasis leans more toward the classic public health protection and promotion in many of the countries we're working with. They're dealing with the fundamental medical challenges of maternal and infant death. They have a need for strengthened family planning so that they can plan and space birth. There's direct evidence now widely available that shows planning births can create much dramatic improvements in maternal health and child health. And of course, the flip side is fewer maternal deaths and children's infant mortality deaths. But they still face environmental challenges. So we've got challenges of TB and malaria issues, as well as HIV/AIDS. That is still a challenge in many of these countries. All of those require a system approach to delivering public health services. They also are concerned about a strong system for service delivery, but they emphasize maternal child health delivery before they move up the food chain, if you will, into acute care and chronic disease. Cancers are starting to become evident. Some of the diabetes and some of those challenges will also become evident in cardiovascular health issues. But most of our work is at the other end of the spectrum, which deals with primary care and health protection promotion projects and programs and district health facilities and initiatives in that realm.
You've made some interesting points here and in the past about the link between a solid health system and the politics of a particular country or the stability of the politics. Is there a real role there? And when you're working on the healthcare delivery system and you become successful with that, are you really fixing other things along with that, or at least affecting other things that are important to a society?
It's a very important arena to have a conversation on. We'll only be able to deal with pieces of it here, but I appreciate you teeing that up. It's very unlikely that we will make much gain or have any significant improvements in the health system performance unless you do pay attention to politics. And certainly you're unlikely to sustain some of the gains that you do achieve by health system strengthening unless you pay attention to politics. Politics gets interwoven into how the society looks at the relative balance of their scarce resources going to health versus education versus job development, building their infrastructure for water, sewer, telecommunications. It's always a challenge when you have limited resources on where you carefully make those investments. Once the money is allocated for the health sector, politics can distort or enhance the equity of how that pool of resources is distributed. In some of the more challenging countries, you have politics influence, so small segments that have political power disrupt the equity equation so that some people get better access to care, better access to resources, better access to employment opportunities in the health sector. In all of this, we find challenges that women face disadvantages. So one of our big mandates is to encourage more women into management and leadership roles and also into governing roles to influence the politics. The last comment I'll make on this is that politics enters not just in forming policy, but implementing policy. And we're finding that the more women are engaged in the policy-making process and the policy implementation process, not only do you have better equity, but more likely to achieve long-term sustainable gains, which is another key motivation in what we're doing.
You have a significant and distinguished career in healthcare in the U.S., and you've had international experience your whole career. Talk to us about some of the surprises we might find as we would walk with you through some of these countries, some of the conventional wisdom that we may hold here that doesn't hold in some of the countries you're working in.
Well, there are some surprises in the sense of the commonality of interests we have. Every society is concerned with the stability of their institutions, especially those that are involved in education, religion, and health. So that's a positive surprise that we all have some common interests, some common frustrations, and a common desire to aspire to higher levels of stability and growth and opportunity for our friends and our families and our neighborhoods. So that's a nice positive surprise. Some of the other surprises are less comforting, and that is the sense that in many of these countries that are still moving through a political and economic development are frustrating themselves and sometimes frustrate the donors on how the resources get used. Corruption is still a challenge in many societies, and one of the perplexing surprises is the hard challenge of dealing with that, sometimes even talking about it. One of the issues that we'll be dealing with in the next 3 years in our project is to look at that third rail of corruption. How do people that are involved in leadership and governing roles have intelligent conversations about corruption and what to do about it, as we are particularly looking at the use of pharmaceuticals, the placement of people into attractive employment posts, access to services, and the like. The last surprise, I suppose, that we could put into our conventional thinking or disrupts a little bit of the conventional thinking is that we think of some of these lower income countries as only dealing with problems of water and sewer and sanitation and nutrition, and those are very key bedrock kinds of issues you have to deal with. Moving from that into primary health care is another common perception, which is true, but the perplexing surprise now is that as they are going through a new era of development, they have this challenge of both communicable and chronic disease. At the same time, they have lower end challenges of communicable diseases as well. So chronic disease and communicable disease all at the same time competing for scarce resources. Those are unpleasant surprises that we have to wrestle with.
What do you see or how do you see, rather, the distribution of manpower? My guess is many of the countries that you're working in are short on highly trained, skilled, educated healthcare workers. To what extent is that a problem for you, and what are these countries going to do about that going forward?
It's a very large and perplexing and not easily solved challenge. The human resource management is a challenge for all societies. There's roughly 195 health systems in 195 countries of the world. Most are dissatisfied with the performance of their health system, and part of it is because they either feel they have inadequate numbers of health workers or maldistribution of health workers. That's true in parts of the United States and Canada. It's certainly true in the lower income countries in which we're working. So we have a challenge of not enough health workers, maldistribution of those health workers. There's still a mentality that if I want a career to help others in the health sector, it's to go into medicine or nursing or pharmacy. There's thousands in many countries moving into community health worker roles, some of which are getting compensated now. All of that is very useful, but a big part of our project is focused in on the missing link, which is health services management is a career path that's not very well understood or valued in many of these countries. And with that lack of value, then you get physicians and nurses that are thrown into positions where they have to manage scarce resources, but with no training, no skills, no attitudes that have been supported and encouraged to grow so they can be more effective. So a big missing link in the maldistribution or the challenge of health workers is that niche that is the people that are going into health services management roles. And a big part of our project is to be engaged in the professionalization of health services management so that mothers and fathers support their children to think of careers of impact, not just good jobs in the health arena. And our view is these opportunities for careers of impact are going to be more likely if we can get clinical background folks to develop some capacity to do leadership and management activities.
I would guess, and based on some of my experience internationally, that when you serve some of these countries, they're just basically trying to keep up. Everything from everyday primary care to trauma care to diseases communicable or chronic. How are some of these countries facing this notion that they're going to be investing larger sums of their gross domestic product as a country gets accustomed to better health care, and do they have the resources to do that? I guess a better way to put that would be, are you guys opening up a floodgate, and what might that mean in some of these countries?
We will journey into the uncomfortable arena and zone of the more lives that you save and the longer you promote healthy lifestyles and lives that not only extend into later years so that the average life expectancy goes up, you'll be pushing them into the uncomfortable situation that we see in the developed world, which is they live longer, but they don't necessarily always live well if they don't practice healthy lifestyles. So we're already starting to see some disturbing trends that obesity and malnutrition are existing in the same communities sometimes, and certainly in the same countries. And so the parliamentarians that we work with are very nervous as they look down the road. How can they afford the service system they've got, which is largely focused on communicable disease and primary health care? And at the same time, they see what is coming down the road over the next 2 decades, chronic disease and the expensive technology and cost that will be largely hospital-based that is going to mean for them. So it doesn't mean that we don't keep people alive and well and healthy, but we also have to pay attention to the economic context, the developmental initiatives and imperatives that these government leaders have to deal with. It reminds us again that the health sector doesn't exist in a vacuum. It's got to be a part of the fabric of the growth in the society as these government leaders try and promulgate policy frameworks that encourage more growth, more harnessing of new technologies that will increase access to better water, more nutrition, better food, to fuel this, because you'll have population growth, population aging, all of which we know from the last 50 years around the world will add to the cost. And unless their economies grow, they'll be in a very tight squeeze going forward. We don't run from that, but we don't. We try to look innovatively about strategies to balance that challenge.
Yeah, as you look at some of the countries in the areas that you're working, some of them are richer than others. They'll have natural resources that are causing extraordinary wealth in these countries. Some of those are draining the brain power and the manpower of surrounding countries. So as some countries in South Asia, for example, are developing a fast-growing nursing market. That nursing market is being taken up by health systems in the Middle East, for example. So as you make progress in these countries and people become more sophisticated as healthcare professionals, is there a risk that they just simply sell their services somewhere else on the globe?
Yes, some government leaders don't view it as a risk. Some are intentionally putting into their economic growth strategy the production of these health workers, almost like a commodity that can be distributed and bring income back to the host country that produces those workers. We see that in some of the countries of South Asia and the Philippines for nurses and some other allied health professionals. Most of the countries we're working will be the low and middle income countries, and so their first level of challenge is how to produce within their own resources the health workforce that they need. That's a big challenge because the employment opportunities, the workplace conditions, the opportunity to earn still isn't as strong and stable and attractive as we would like it to be, as contrasted to some of the hospitality, the tourism, the telecommunications. So all of that has got to be balanced, and the health leaders of today and tomorrow must have that broader globalization context in mind. The movement of health workers, positive and negative, is a piece of the equation. The other important thing that you brought up, Dan, is the use of natural resources. Many of the countries we're working do have dramatic wealth in the extractive industries, petroleum, mining, chemicals. Unfortunately, still in many of these countries, the wealth is concentrated in a small proportion of the population. So one of the real challenges, going back to the issue of politics, is how to get equitable access and use and investment of those resources back into the full society to improve not only the access to health workers that they need, but to the health services that those health workers can provide.
In the U.S., we seem to value health at almost any price and almost to any extreme. What have you been taken by as you visited these countries relative to the value of health and health care based upon your foundation in the U.S. value system?
There seems to be something I've found over the years in the human genome that values the health of my family, my community, and then ultimately the nation. So there's an inherent pursuit and desire and aspiration to be healthy, be healthier, but oftentimes population groups and health districts and even families need to be supported on what factors are more likely to interrupt good health and how to avoid those factors, those threats, those risks, and what behaviors and what interventions have higher evidence base that will enhance health. So there's always going to be the challenge of imparting knowledge at the fundamental community and family level so that people are forewarned and forearmed and equipped to pursue health on their own. But there's always a desire to have it. They see the good that can come from good health, a capacity to earn, a capacity to enjoy the life around you. But the more we avoid conversations about the factors that disrupt healthy lifestyles and healthy communities, the more we leave in peril these communities and these nations. So we have to have more conversations, and we have to have more evidence base of what is working and what isn't, and how to impart that into these at the community level. We have in our project from the village to parliaments that we pay attention to this use of evidence-based decision-making and more people aware of how to use that information wisely for better health.
I suspect that there's a lot of fulfillment in going into these countries and providing the education and the development of the systems that you do. Two-part question here. How do you make sure that your efforts are sustainable, and what do you measure to know whether you're doing any good or not?
Yes, it is a challenge. Many days there is a sense of satisfaction that we're doing something that makes sense and will stick, will be sustained. Oftentimes we also run into frustrations where the system isn't working well, and there's factors from politics to lack of knowledge or approach to leadership and governance that are getting in the way of that impact being well felt and well understood, and certainly whether it can be sustained is always an open challenge. Our mandate from the U.S. government is to find evidence that shows and builds the case that investing in smarter leadership and management and governance will in fact lead to stronger health systems that perform more wisely and ultimately lead to outcomes. So sustainability of this is a huge challenge. It will always be a challenge where you have resource-constrained societies that are relatively early in their development cycle on the political infrastructure and building the institutions they need to survive. But it has to be front and center on everything we do, sustainability of strong and significant gains in healthcare. The way we're paying attention to that is to not just train clinicians, but to train people that have a mindset and a skill set that looks at leadership and governance kinds of activities. That makes a contribution to sustainability, but again, no guarantees. So it is a perennial challenge that we'll all have to be involved in. There are probably about 40 major donors that are involved in international assistance in these countries that are facing challenges of low and middle income. And there's finally a common exchange of ideas and wisdom about what's working and what isn't to sustain gains. And that exchange of ideas and resources between donors and between governments, the South-South knowledge exchange you hear talked about so much, is going to help make not only more significant gains, but more sustainable gains. So we're optimistic about that, but we're not naive about how easy that will be to achieve.
Who do you partner with?
Our specific project has 5 international partners. We work with Yale on some unique training initiatives for ministries of health. We work with Johns Hopkins to help us build the evidence base for this. We work with the International Planned Parenthood Federation based out of England. They have 170 member associations The U.S. is one of those member associations. We work with an organization called the Africa Medical Education Research Foundation in Africa, based in Nairobi, for some middle management training and development activities and to get more women into leadership. And we also partner with a small technology firm whose claim to fame was to use the cell phone to link community health workers and district health posts. We're trying to use those cell phones to move information for smarter leadership and governance decision-making. Those are our 5 major partners, but we also work with other donors from DFID in England, World Bank, World Health Organization. We also have established some exciting memorandums of collaboration back with some of the strong organizations in the United States. We have an agreement with the American College of Healthcare Executives. We have an agreement with the American College of Physician Executives. We have an agreement with the Board Source, which helps support governance of some civil society organizations. We have an agreement with the Leadership Academy that has come out of the National Health Service in England to help on our competency-based leadership tools. And we are also working now with the International Hospital Federation, because one of the things that we want to have as our legacy is to leave behind health professional associations, because that contributes to lifelong learning, which is an important part of our legacy also.
So when you think about successes, if you were standing in front of your board and you said, I can name off some successes that shows that your efforts and our efforts together are paying off, what would be some of those successes?
It's early on in our project, but fortunately we're able to build on about 15 years worth of activities from the Management Sciences for Health. We have a number of successes that build up from the individual medical and health challenges that we're wrestling with over the years. There are successes on the coverage rates for childhood immunizations, when managers know how to identify gaps in health needs and responses to those needs, and they can assemble the right people in the right place in the right time to have service delivery occur, to manage supply chain for immunizations, to manage the social media for getting people to come in for immunization activities and to maintain their immunization, and to weave that into education of women and family units to understand the value of immunization. We can show rapid increase in coverage of immunizations and sustained health that comes from immunizations. We also have evidence that shows that stronger leadership can result in better access of women to prenatal care, and to have a new balance between traditional birth healers and support with more professional support. And the more women that can get into safe deliveries, the more maternal infant death rates go down and health goes up. And that evidence comes about when leadership is devoted, not just clinical leadership, but managing education processes, infrastructure for service delivery, making available the medicines and the technologies and the facilities that you need in the right time, even in remote and sparsely populated and environmentally challenged environments. That can make a difference as well. We're also finding evidence that now this new generation of attention on those that are involved in governing are important. In Afghanistan, where we have 120-some staff, there's 107,000 people involved in governing roles at the district and shura and provincial levels, many of which don't have the training and support they'd like to make good decisions, to create the conditions in which people that manage and lead can do their art and science. And if the people that are doing leadership and management aren't doing their work, the people with the clinical backgrounds in medicine and nursing can't get enabled and facilitated to do their work. And so this chain of logic, we're finding evidence along all path steps of that journey that are really heartening and encouraging us to go more. We still need a lot more evidence, but your question is a good one, and it's a challenge that we are going to have to continually wrestle with.
You're going to have, or we're going to have, quite an audience, or a wide audience for this particular interview. What are the opportunities for our students that are thinking globally?
We really need to impart to the students and to the faculty the interconnectedness we have with globalization going on. not just from biomedical threats, bioterrorism threats, that there's enlightened self-interest that we should be wiser on how health and health care plays out in other nations, because if we don't, and if we don't in fact play an active role, it could come back to harm us in a negative way. However, on a more positive sense, there are a lot of opportunities in these countries. Half of the population is going to be in low and middle income countries. There's an opportunity for economic growth. There's an opportunity for people that are graduates of whether it's epidemiology or schools of public health traditional graduates, or those that are involved in clinics and chronic disease and hospital care. People that have some experience and interest in making those elements of the system work wisely and well will have a lot of opportunities, not just in the low and middle income countries where we're working, but in other well-developed countries as well. Globalization is creating an opportunity for medical tourism, biotech, biomedical, technology development. People that have an interest in doing well by doing good in the health sector recognize that the health sector's got a wide array of segments within it, ranging from protecting and promoting health to new forms of technology, harnessing new apps and cell phones that can inform both clinical and administrative decision-making in remote areas, because cell phone technology is growing more rapidly than landlines. So I think the bottom line message for our graduates is it's a huge opportunity in health. All populations are going to continue investing in health, and people that have some special acuity and training and leadership and management can really do a great deal of good, have a lot of fun, make some decent incomes, and really feel satisfied that they're making the world a better place.
Anything else our students and our viewers should understand from you about this?
I think one thing I would encourage students to do is to put pressure on the faculty to really enrich their learning experience. And so that comes back to something that you and I have talked about over the years, which is we always need to look at faculty development in this equation as well. We need smart, sharp people that really have a hunger to build knowledge and share it and impart it back to students. The best faculty over the years I've seen are those that balance the traditional tripartite challenge of finding knowledge, advancing knowledge, teaching, doing research, doing community service, doing consultations. And the more we can have faculty work outside the U.S., be boundary spanners of both nations and health sectors, the better off our graduates will be, the better off this university will be, and the better off the world will be. So I think we'll find an opportunity, hopefully, in the future for conversations about faculty exchanges, because, as you know, we're trying to build up the faculties in these 20 or so countries that we're working, so that the faculties are developing curriculum and learning experiences, embracing team teaching and team learning and experiential learning and case-based learning that will really be good. And I'd like the students to be champions for that inside the university, so that we have university leaders such as yourselves and other faculty really help make that a really positive part of the legacy of this university and a legacy of the impact that students and faculty make around the world.
Well, Jim, on behalf of the University of Minnesota MHA program, all our alumni, all our students, I want to thank you not only for today, but all the contributions you've made to the program, to healthcare in the U.S., and now on a global perspective. So thanks so much, Jim. It was a pleasure.
Thank you, Dan. We're all learning, and I've very much appreciated the chance to learn here at the University of Minnesota.
Always nice to have you visit. Thank you.